You know, usually when we talk about a medical treatment plan, there's this expectation of like total precision.
Right, yeah, like reading a map.
Exactly, like a map. You have symptom A, you take medication B,
Yeah.
and your doctor just sort of points to the destination and says, there it is, we have arrived.
It's binary. I mean, it's predictable. And honestly, it is very comforting for both the patient and the physician. We all like things to be standardized, to just fit into neat little clinical flow charts, you know?
We really do.
Yeah.
But then you step into the world of highly specific personalized medicine.
Oh, yeah. That's where it gets messy.
Right. When you take this trendy, modern procedure and try to layer it over a complex, deeply scarred medical history, that pristine map just catches on fire.
It really does. It goes up in smoke.
And today, we are unpacking a case where that map goes up in absolute flames.
Mm.
So welcome to the deep dive. We're looking at a very specific patient profile today. A woman with a history of advanced, treated female genital tuberculosis.
Which is a whole thing on its own.
Totally. And she is now seeking out a procedure called the O-shot, which is a vaginal platelet-rich plasma injection. And she wants this to treat her postmenopausal symptoms.
It is a hyper-specific patient profile, I mean, no doubt, but the biological mechanisms at play here are completely universal.
Yeah, that's what's so crazy about this.
Right. The implications of this single scenario, they just ripple out into how we view immunology, the hidden dangers of hormonal therapies, and really the entire landscape of cosmetic gynecology.
And if you were listening to this right now thinking, well, look, I don't have genital tuberculosis, so why do I care? Stick with us.
Please do.
Because if you have ever been prescribed a new medication or if you've ever even considered a cosmetic procedure, you probably just assumed the word safe was, universal.
Right, that safe just means safe for everyone.
Exactly. But this deep dive proves that safe is completely relative to your unique biological history. The human body does not forget its past.
It keeps the receipts.
It keeps all the receipts. So, okay, let's unpack this. We've got a great stack of sources today. We're pulling from ACOG committee opinions on vaginal procedures, clinical studies comparing PRP to hormonal therapies, some intense immunological research on platelets, and a few really wild medical case reports.
Including one about IVF that is just, well, we'll get to it, but it's staggering.
We will get to it. So, when you have a patient whose map has caught fire like this, where do you even begin? Usually you look at what's bothering them right now today.
Right, the immediate complaint.
Yeah. In this case, a postmenopausal woman is seeking relief from severe tissue atrophy. Let's start with the mechanics of why she would want this O-shot in the first place.
Well, we really have to establish the baseline of her suffering first. When a woman enters postmenopause, her body just stops producing high levels of estrogen.
Right.
And estrogen isn't just like a reproductive hormone, it is the fundamental architect of vaginal and urinary tract health.
The architect. I like that.
Yeah, I mean, it keeps those tissues thick, elastic, and well lubricated. It does that by maintaining local blood flow and cellular turnover.
So when that estrogen production plummets, the architecture basically collapses.
Exactly. It caves in.
We're talking about a condition known as vulvovaginal atrophy, or VVA. The tissue literally thins out. It loses its elasticity. And this leads to severe vaginal dryness, stress urinary incontinence.
Which is where coughing or laughing causes leaks.
Right, yeah. And also dyspareunia, which is the medical term for highly painful intercourse.
It is a condition that drastically erodes a woman's quality of life. And for decades, I mean, the absolute gold standard for treating this has been local topical estrogen therapy.
Just putting the estrogen right back where it's missing.
Right. You apply an estrogen cream directly to the area, you replace the missing hormone locally, and the tissue rejuvenates, it plumps back up. But recently, we've seen this massive surge in the popularity of the O-shot as a hormone-free alternative.
And the mechanics of the O-shot are pretty fascinating. I mean, it relies on autologous platelet-rich plasma, or PRP.
And autologous just means it comes from your own body.
Exactly. You go into a clinic, they draw a vial of your blood, and they put it in a centrifuge. The machine spins the blood at a super high speed to separate the red blood cells from the plasma.
Isolating that liquid gold.
Yeah, this highly concentrated serum of your own platelets and growth factors. Then they take a syringe of that concentrated plasma and they just inject it directly back into the vaginal tissue and near the clitoris.
The clinical appeal is enormous. I mean, it's marketed as a fast, 30-minute, completely natural procedure.
And it does work, right? Like, the data supports it.
To be fair to the procedure, yeah. Clinical trials comparing topical estrogen to these PRP injections for postmenopausal atrophy show remarkable results. PRP significantly improves both the female sexual function index and the vaginal health index.
The numbers are undeniably impressive. In some of these trials from our sources, the PRP groups hit a satisfaction rate of over 93%.
Which is huge.
It's massive. It's essentially going toe-to-toe with standard estrogen treatments. I like to think of PRP as a sort of biological fertilizer for dried-out soil.
Oh, that's a great way to visualize it.
Thanks. You are basically extracting the body's most potent regenerative growth factors, concentrating them, and injecting them into parched tissue to force deep cellular rejuvenation.
Biological fertilizer is incredibly accurate. It actively promotes new blood vessel formation and tissue regeneration. However,
There's always a however on this show.
always,
Yeah.
before we declare it a miracle cure, we have to look at the official stance of the governing medical bodies. The American College of Obstetricians and Gynecologists, or ACOG, has issued Committee Opinion Number 378.
And they are not as thrilled as the marketing brochures, are they?
No, they throw a very significant bucket of cold water on these cosmetic vaginal rejuvenation procedures.
Because they point out that the O-shot isn't actually medically indicated. It's considered an off-label use.
Exactly. ACOG explicitly states that the long-term safety and effectiveness data for these procedures simply haven't been rigorously documented yet.
So they're urging extreme caution.
Very much so. They point out that injecting fluid into this highly sensitive area carries general risks even for perfectly healthy women. You run the risk of introducing an infection, altering nerve sensation.
Which is terrifying.
Right, causing chronic pain or creating new adhesions and scarring.
Okay, so we have this highly effective, very popular procedure that uses your own blood, but the mainstream medical establishment is still looking at it with a massively raised eyebrow.
Yep, the eyebrow is firmly raised.
So let's bring this back to the woman sitting in our hypothetical clinic. A postmenopausal patient with a history of treated female genital tuberculosis. If the O-shot is considered experimental by ACOG, why on earth wouldn't this patient just use the standard FDA-approved estrogen creams for her atrophy?
Why take the risk with a new injection?
Exactly. Just use the cream.
Well, that is the pivotal question of this entire case. And the answer lies in a really terrifying hormonal catch-22. To understand why she needs to avoid standard treatments, we have to look at what estrogen actually does to the human immune system.
Because it's not just a reproductive thing.
Right. Estrogen does not just stay localized. It has profound systemic effects on how our bodies fight off disease.
Okay, I need an ELI 5 on this. Explain it to me like I'm 5. Because usually we just think of estrogen as, a sex hormone. How on earth is it interfering with the immune system?
Let's break it down. When you introduce high levels of estrogen into the body, it acts as a very specific kind of immunosuppressant.
Wait, really? It suppresses the immune system?
Yes. Primarily, high estrogen states suppress what we call the T helper 1 pro-inflammatory response.
Okay, stop there. T helper 1. What is that, practically speaking?
Think of T helper 1 cells as the immune system's first responder coordinators. When a dangerous intracellular bacteria like tuberculosis enters the body, the T helper 1 cells sound the alarm. They orchestrate the cellular attack to destroy or contain the invader.
Okay, they're the security guards.
Exactly. And estrogen actively suppresses those specific coordinators. Furthermore, estrogen increases what we call paracellular permeability and vasodilation.
Vasodilation, I know. That's when blood vessels widen and open up. But paracellular permeability, what's that?
Paracellular refers to the microscopic gaps between the cells that line your blood vessels and tissues. Estrogen actually causes those tight junctions to loosen up.
So it's making the walls leaky.
Yes. So if we go back to your metaphor, introducing high estrogen is like firing the security guards, the T cells, and then leaving all the doors wide open by increasing the permeability of the tissue.
Oh, wow. That is a terrifying combination if you have a dangerous bacteria lurking anywhere in the building.
It's a recipe for disaster.
And this isn't just theory, right? I mean, looking at the sources, there's this incredibly dramatic medical case report that perfectly illustrates how dangerous this estrogen mechanism can be for someone with a history of TB.
It is honestly one of the most striking case studies in recent gynecological literature. It involves a 28-year-old woman suffering from secondary infertility who opted for in vitro fertilization.
IVF. Yeah.
Now, as part of the standard IVF protocol, a patient undergoes controlled ovarian hyperstimulation,
Right. The doctors give her medications to make her ovaries produce multiple eggs at once.
which naturally causes her internal estrogen levels to absolutely skyrocket. During her stimulation, her serum estrogen reached a massive peak of 1,725 picograms per microliter.
Wow. For context for you listening, that is an astronomically high hormone state.
Off the charts. Now, here is the critical twist. This woman had no known history of active tuberculosis. However, she had suffered a previous ectopic pregnancy, a pregnancy that implanted outside the uterus in the tube.
Okay, so a red flag right there.
Right. In hindsight, the medical author suspected that ectopic pregnancy was actually the result of a silent, hidden case of pelvic tuberculosis that had damaged her fallopian tubes years prior.
So she goes through the IVF, and it works. She gets pregnant, but by her 9th week of gestation, everything just goes wrong.
Completely wrong.
She develops a severe fever of 40 degrees Celsius. That's 104 degrees Fahrenheit. And tragically, she ends up spontaneously aborting the pregnancy.
And at this point, the doctors are just scrambling. They're trying to figure out what caused this catastrophic systemic failure. When they finally perform a chest CT scan, they find a classic diffuse miliary nodular pattern in her lungs. She had acute miliary tuberculosis, meaning the bacteria had spread aggressively through her bloodstream and seeded her lungs with countless tiny lesions.
But it started in the pelvis.
Wow.
Because when they tested her uterine curettage, which is when they gently scrape the inner lining of the uterus, the endometrium, to test the tissue, it came back positive for Mycobacterium tuberculosis RNA.
Yes. The infectious granulomas were right there inside her reproductive tract.
So let's connect the biological dots based on what you just said about estrogen. The medical consensus for this case is that the massive estrogen spike during the IVF stimulation completely inhibited her T lymphocyte function, right?
Precisely. What's fascinating here is that the estrogen essentially fired the security guards, keeping that dormant pelvic TB infection in check.
It unlocked the cage.
It did.
Yeah.
And the increased vascular and paracellular permeability from the hormones meant the doors were wide open. The bacteria escaped the pelvis, entered the bloodstream, and disseminated all the way to her lungs.
That is just staggering. So bringing this back to our postmenopausal patient with a known history of genital TB, if she uses standard local estrogen therapy to treat her vaginal atrophy, she might theoretically be creating that exact same reactivation risk.
Yes. By introducing hormones, she is inhibiting the T lymphocyte function in her pelvic region. It creates a window for any surviving bacteria to wake up and spread.
Which is exactly why a non-hormonal option like the O-shot suddenly looks like the safest, most logical alternative on the board. PRP doesn't use estrogen. It doesn't suppress T cells.
Exactly. So the logic tracks. She avoids the hormones, she dodges the immune suppression, and she gets the PRP injection. Problem solved, right?
Well, as we often discover in these deep dives, biology is never that simple.
I knew that was coming.
Yeah, I couldn't resist.
Yeah.
So we've established why the hormones are a bad idea. But now we have to pivot and look at the physical anatomical reality of what we are actually doing. We are talking about plunging a needle into a pelvis that has survived advanced tuberculosis.
Right. We really need to understand the mechanical legacy of female genital tuberculosis, or FGTB. And I want to stress that this is not some incredibly rare localized anomaly. Globally, FGTB is incredibly common.
Yeah, the sources said the prevalence reaches about 27% in some populations. That is huge.
It's a massive global health issue, and when the tuberculosis bacteria attack the female reproductive system, they do not just cause a temporary inflammation. They are ruthless.
They destroy everything in their path.
Pretty much. The infection primarily targets the fallopian tubes in nearly 100% of cases, and it invades the endometrium, the inner lining of the uterus, in over half of the cases. But it can also affect the cervix, the vagina, and the vulva.
But what's critical to understand is how the bacteria damage the tissue. It's this cycle of chronic destructive inflammation. The body tries to wall off the infection by producing large amounts of fibrin, right?
Yes, fibrin is a protein involved in blood clotting. So this massive overreaction creates huge adhesions, We are talking about internal organs, the bowels, the ovaries, the uterus, literally scarring and fusing together into dense webs of tissue.
It completely destroys the delicate fimbrial structure on the fallopian tubes, and it can create these deep pockets of infection called collar stud abscesses.
And in the most extreme advanced cases, this chronic inflammation leads to the extensive destruction of both the endometrium and the myometrium, which is the muscular outer wall of the uterus.
Right, which causes a complete obliteration of the uterine cavity.
Exactly. That specific condition is known as Netter syndrome. The inside of the uterus is basically glued shut with dense scar tissue.
Okay, so visualize that pelvic landscape for a second. To perform the O-shot, a practitioner has to inject fluid deep into the vaginal walls and the clitoral complex. But injecting a needle safely requires predictability, doesn't it?
You absolutely need predictability. You need to know exactly where the blood vessels are, where the nerve bundles sit, and how the plasma is going to diffuse through the tissue once you push the plunger.
Here's where it gets really interesting. If a patient has a history of advanced FGTB, their pelvic anatomy is gone. The map is useless.
It's completely distorted.
It might be a literal minefield of fibrous adhesions, altered blood flow, and dense scar tissue.
Which brings us right back to that ACOG committee opinion we talked about earlier. They warned that cosmetic vaginal injections can cause nerve damage, severe pain, and bleeding even in perfectly healthy, predictable tissue. So if you take that needle and drive it into a heavily scarred FGTB pelvis, the mechanical risks just go through the roof. You have a massively elevated chance of striking a displaced nerve bundle. Or the plasma might just fail to diffuse because it hits a solid wall of internal scar tissue, creating a painful pressure pocket.
The physical risks are undeniable. But, okay, let's play devil's advocate. Let's assume the practitioner is highly skilled. Let's say they use ultrasound guidance, they navigate the scar tissue perfectly, and they deliver the plasma safely without hitting a nerve.
Okay, best case scenario.
Best case. We still have not addressed the final and perhaps most dangerous layer of this deep dive.
Right, because we haven't talked about the platelets themselves yet.
Exactly. So beyond mechanical risks of the needle hitting scar tissue, what happens on a microscopic level when you drop millions of concentrated blood platelets directly into an environment that previously hosted tuberculosis?
This is where the safety profile shifts from a structural mechanical concern to a profoundly complex immunological paradox.
It's the platelet paradox.
Yes. We have to look at what platelets fundamentally do when they encounter Mycobacterium tuberculosis.
But wait, I want to push back on this a little. The entire premise of this case is that the patient is treated. The genital TB is in her medical history. If she went through the antibiotic regimens and the TB is considered dead, why does it matter how platelets react to the bacteria? There shouldn't be any bacteria left, right?
Well, if we connect this to the bigger picture, that assumption relies on a slight misunderstanding of how tuberculosis operates. TB is arguably the most successful pathogen in human history precisely because of its ability to hide. We have to talk about latency.
Latency, okay.
Up to 90% of individuals infected with TB harbor a latent form of the disease. The bacteria enter a quiescent or resting metabolic state.
And basically go into hibernation.
Exactly. They hibernate, and the immune system traps these hibernating bacteria inside granulomas, which often have a center made of caseous material.
Caseous.
Caseous literally translates to cheese-like. It's a necrotic, dead tissue bunker where the dormant bacilli can survive for decades.
That is so gross, but also amazing. Okay, so treated does not equal a 100% sterile eradication. It just means the immune system and the antibiotics fought the bacteria to a standstill, forced a ceasefire, and the survivors retreated into these microscopic, cheese-like bunkers deep in the pelvic scar tissue.
Precisely. The bacteria are asleep, but they are not necessarily gone. And this is where injecting the autologous platelets from the O-shot becomes a massive potential liability. Recent cutting-edge immunological research reveals that platelets actively regulate pulmonary inflammation and tissue destruction in tuberculosis.
And this was the part of our deep dive prep that completely broke my brain.
That's wild.
It's so counterintuitive. You would naturally assume that platelets, being a core component of our blood, would help the body fight off an infection. But the science shows that platelets actually restrict the oxidative burst in phagocytes.
Let's unpack that mechanism because it's so vital. Phagocytes are the immune system's Pac-Men.
Waka, waka, waka.
Exactly. They are white blood cells designed to engulf and gobble up bacteria. Once they have swallowed a tuberculosis bacterium, they need to destroy it. To do that, they unleash a massive release of reactive oxygen species directly into the vacuole holding the bacteria.
That is the oxidative burst. It's essentially the immune system using a microscopic chemical flamethrower to burn the bacteria alive.
Well, that is exactly what it is, a chemical flamethrower. But the research demonstrates that when platelets interact with these phagocytes, they actively restrict that oxidative burst. If we use your metaphor, the platelets are basically dumping water on the immune system's flamethrower.
That is insane.
They disarm the phagocyte, which actually facilitates primary progressive tuberculosis.
They disarm the immune system's primary weapon. Wow.
It gets worse. When researchers analyze active TB infections, they find incredibly high levels of two specific things: platelet factor 4 and VEGF-A.
VEGF-A.
Right, which stands for vascular endothelial growth factor A. High concentrations of both of these are strongly correlated with granulomatous inflammation in active TB.
Which is the exact type of destructive tissue-wrecking inflammation that tuberculosis uses to spread and survive. And let me guess what one of the primary, heavily concentrated growth factors found in a syringe of platelet-rich plasma is.
It is VEGF-A. That is the exact growth factor the O-shot relies on to stimulate new blood vessels and rejuvenate the vaginal tissue.
Oh my gosh. So let's synthesize this whole picture. You have a patient with a history of genital PB. She has dormant bacilli hiding in scar tissue bunkers in her pelvis.
Right.
To treat her vaginal atrophy, you decide to inject her with millions of concentrated platelets and massive localized doses of VEGF-A.
Right.
You are actively injecting the exact biological agents that dump water on her local immune system's flamethrower, alongside the exact growth factor that feeds TB-related granulomatous inflammation.
Yes. You might theoretically be providing those dormant bacilli the absolute perfect biological environment to wake up, break out of their bunkers, and resuscitate. It is a theoretical but profoundly concerning immunological perfect storm.
It's like you're handing the bacteria the keys to the city.
This is precisely why the medical literature explicitly lists active infections and immunosuppressant conditions as hard contraindications for PRP therapy. In a patient with a history of FGTB, you are walking a razor-thin line between cosmetic rejuvenation and systemic reactivation.
So what does this all mean for you listening to this? Let's zoom out and synthesize everything we've uncovered today, because this is the definition of a high-stakes medical balancing act.
It really is.
On one side of the scale, you have the very real, very valid suffering caused by vulvovaginal atrophy. This patient is in pain, and she wants relief. And because standard estrogen therapies act as systemic immunosuppressants, which we saw tragically reactivate TB in that IVF case study avoiding hormones, makes the O-shot look like a brilliant, hormone-free alternative.
It seems perfectly logical on the surface, but on the other side of the scale, you face severe mechanical and immunological realities. Mechanically, you are driving a needle into a pelvic landscape that could be ravaged by Netter syndrome, full of dense adhesions and altered anatomy.
Which drastically increases the risk of nerve damage or bleeding, just like ACOG warns against.
And immunologically, you run face first into the platelet paradox. By flooding that scarred pelvis with concentrated platelets and VEGF-A, you risk disarming the local phagocytes, stopping their oxidative burst, and potentially giving the dormant tuberculosis bacilli the exact molecular cover they need to reactivate and spread.
Which turns an elective, 30-minute outpatient procedure into an incredibly delicate, high-risk endeavor.
Absolutely.
And I think, more than anything, this deep dive proves why a one-size-fits-all approach to medicine is inherently flawed.
Yeah.
You can have a procedure like the O-shot that boasts a 93% satisfaction rate in the general public. It's quick, it uses your own blood, people love it.
Right.
But when you overlay that same simple procedure onto a unique medical history like genital tuberculosis, the implications completely invert. You can't just follow a standard flowchart.
Because the flowchart assumes a standard biology. And there is no such thing when you factor in a history like FGTB. You have to understand the microscopic mechanisms at play for the specific individual sitting in front of you.
Well said. Now, before we wrap up, we always like to leave you with a final thought, something to mull over that builds on what we've discovered today. And based on that platelet paradox research, you had a really fascinating takeaway about the future of infectious disease.
I did, yeah, because it pushes the boundaries of how we might treat these ancient pathogens. If we now know that platelets play such a definitive active role in restricting the immune system's ability to fight off tuberculosis, it begs an incredible question.
Oh, this is good.
Could something as simple as anti-platelet drugs like taking your everyday over-the-counter aspirin one day become a primary life-saving treatment to help patients finally eradicate TB?
Imagine that. A simple aspirin taking down one of the world's oldest, most resilient bacterial enemies just by stopping the platelets from interfering with the immune system.
It completely flips the script on how we handled the disease.
That is definitely something to think about. Thank you for joining us on this deep dive into the complex, murky waters of the OSHOT and FGTB. Keep asking questions, and we'll see you next time.